for Financial Assistance Policy, Learning New Requirements to Stay Compliant. My name is Joe Moretti, and I'm part of the business development team here at the Ridiculously Nice Collection Agency, AmeriCollect. I am happy to be your moderator for today's session, and I do have the pleasure of introducing Sean Gretz. But before I do, I'd like to show you how to ask questions during the session. On the right-hand side of your screen, there's an area that you can type out questions if you should have any during this webinar. I will interject these questions to Sean during the session if there is time available at the end. Sean Gretz is the Vice President of Sales and Marketing here at AmeriCollect and AmeriEBO. Sean has hosted multiple webinars, visited many facilities, and has spoken nationally on the topic of 501R. Sit back and enjoy the webinar as I welcome Sean.
Thank you very much, Joe. I appreciate the introduction, and welcome everyone to, I think this is my 7th edition of 501R Talks. I'm glad you're here. You must be my 9:30 folks, the individuals that had the luck of waiting till the end to implement 501R. If you're not one of those individuals, and if you're just a little bit behind, that's okay as well. You can listen in as well. But I'm here as a reference. I always say that in this webinar is I'm here to help in any way possible that I can. And by that, what I mean is I have reviewed over 50 different policies, billing and collections and financial assistance policies. So if you need help, and if you're struggling, if you need someone to take a look at your policies and give you some free suggestions, and I do this completely free, out of the goodness of my heart, I give it to you. Send me your policies. I'll take a look at them. I'll give you some suggestions on what other facilities are doing, and if you have some difficult questions, I bet you I probably give you, and there's the Wisconsin link, betcha. I bet you I can give you some help on it because of all the times that I've helped other facilities. Or if I don't know the answer, I know I can reach out to one of the other facilities that I've helped out and ask them how they're handling that. So, like Joe said, to give me a little introduction, I am not a lawyer, nor do I play one on TV. If you're seeking a legal advice, please make sure you consult your attorney. Who we are, I have to start this out as the Vice President of Sales. I got to tell you a little bit about us. We've been in business for 50-some years. We're the Ridiculously Nice Collection Agency, as Joe says. We do Ridiculously Nice Collection Agency and Extended Business Office or Early Out Services. We do both. So we are a 250-team agency out of Wisconsin, and we love healthcare. It's because it's all we do is healthcare collection. So that's why I'm here. So let's start out with what the IRS said on this one. So the IRS is the one who released this law. And part of 501R, they said that it would only take you 60 hours of record keeping in order to implement 501R. 60 hours. Now, everyone on the line, have you spent more than 60 hours on 501R? And I think the answer is going to be, of course we have. 60 hours, are you kidding me? Yeah, that's what IRS said. You guys, it would take you only 60 hours for the amount of work to put this on. But I laugh at that because the likelihood that you spent more than 60 hours is or if you haven't spent 60 hours yet, just keep in mind, it's going to take you a long time to implement this. It's going to take you longer than 60 hours. So I always like to say this is my meat and potatoes presentation, meaning that I'm going to do the cardinal sin and give you a bunch of words on every single slide. But those words you can take. You can utilize them at any given point. So just remember that as well. There's other things that I want you to be aware of. There's page numbers on slides. Those page numbers correspond to a document released by the IRS. It's where I got all my material from, or most of my material from, besides some of my clients that I've reviewed their policies. Those page numbers correspond to that document. If you want that document where I got it, it's the pre-publication release from the IRS. Just let me know, and I can email it to you. My email, I believe, is on my last slide. I have some examples in here. Take a look at those examples. Use those examples. Those are free for you to use. So if you're still writing your policies, or if you like my language better than yours, or you want to steal something from those examples, take them. And then the smiley face, like I said, we're the Ridiculously Nice Collection Agency. Smiley face is some of the things we use for marketing, but those smiley faces are our examples. Again, take those and use those as well. So like I said, pre-publication documents. If you would like that pre-publication document, just go ahead, send me that email, and I'll get you that pre-publication document. So a little bit of background. 501R was part of the Affordable Care Act. The beginning of it was released in 2012. They had several different releases of it because there had many questions. Of course, the IRS is not known in the healthcare industry to know everything that goes on currently. So when they released the regulations the first time, they had a ton of questions. And when they released the second edition, they had a ton more questions. And then when they released the final, I'm sure they got a ton more questions. So it was part of the Affordable Care Act. It really created three main things, 501R did, or four main things actually, but the three main ones that I cover mostly is 501R4, which is your Financial Assistance Policy, or FAP, 501R5, which is your Amounts Generally Billed section, and 501R6, which is your Extraordinary Collection Actions, or ECAs. The fourth one is the Community Health Needs Assessment as well. But when you see me talk about these terms, so if you see an FAP, understand that it stands for Financial Assistance Policy. If you see AGB, you understand it stands for Amounts Generally Billed. And when you see ECA, understand it stands for Extraordinary Collection Actions. Let's talk about the timeline. The timeline for offering financial assistance, and this is one of the major changes part of 501R. It requires that you process an application from the date of discharge all the way through 240 days from the date of the first post-discharge statement. So you have to accept a financial assistance application all the way through that time frame. From the date of discharge all the way through 240 days from the date of post. Excuse me, I got a little tickle in my throat. All the way through the 240 days from the date of the first post-discharge statement. That is one of the major things you have to understand about 501R. There is an extended time frame, even if it's at your collection agency. At any given point in that 240 days, you have to accept and process an application. So remember that. It's one of the major changes that we're going to be discussing. So what are some of the other things that I'm going to cover today? Number one, what changes I suggest you make to your financial assistance policy, or what are the required changes? Number two, what is a plain language summary? Number three, what does it mean to be widely publicized? So let's dive in. Let's talk about first prior applications. One of the requirements of 501R is that you state in your policy if you're going to use prior applications and how long you're going to be able to use prior applications. So currently right now, if your policy does not state how long you're going to use prior applications, you will need to update your policy. And I'm going to give you some examples coming on in the next couple slides. Let's move on. Another requirement, you have to state the date that you're going to use to make a qualification. And by that, what I mean, are you going to use the service date or the date of service from the patient, or are you going to use the date that the application is turned in, or another date completely separate from that? But you have to state in your financial assistance policy what date you're going to use. And why this is a big deal? It's because an individual's financial situation can change drastically in 240 days. An employed patient could be unemployed and financially struggling 240 days later. This is very important that you take a look at this and understand what date are you using to make the determination of qualification. So let's look at some examples. I'm going to give you two different examples on this screen, and I'm going to give you a third, and I think I'm going to give you the best one. Example number one, and this comes from one of my clients' financial assistance policy that they've written earlier this year. What they're using by looking at this thing is they're saying, remember when I talked about the prior applications? They're using a 6 months prior, meaning that an application can be used 6 months into the future and 6 months prior, excuse me, to make that determination. That's one of the requirements. Make sure that you have in there how long that application is good for. The second part of it is that they're going to be, I'm sorry, I said that incorrectly, that they're using 6 months prior to make that determination. If this facility makes the determination that they're qualified, they're going to go 6 months prior, and any bill 6 months prior will also be determined financial assistance. And each time of service, they're going to be reevaluated for financial assistance. So this is one way to work the prior applications in and the length of time that they qualify for. The second way, another example, is going to be made effective for a period of 6 months from the date of the application. This is the important part. What they have in here, they're stating that it's from the date of the application. But they also added something else in here, including all outstanding receivables, including those at bad debt agencies. So what this facility is doing is they're taking all those that qualify for financial assistance from the date of the application and removing all old accounts that are at the receivables are at the bad debt collection agency. So reclassifying accounts at the bad debt collection agencies. I would suggest on this one, especially looking at this one, there is one qualification that I would make on this. And the reason why I would make the qualification on this is part of 501R requires you to refund any payments to any qualified patient. So if they qualify for financial assistance and you received any, you're going to have to refund them. So my suggestions to you, my strong suggestions, there's a little bit change to that, and I'm going to show it to you in my suggestion. So here's the third example, and this is the one that I've taken from 50 different examples and combined them all together. So what I think is one of the best ways to word this. A determination of financial assistance will be effective from the period of up to 6 months, including subsequent emergent and medically necessary care from the date of the application, remember that's important, date of application or date of service, and was approved, and it will include all outstanding receivables, including those at bad debt agencies, unless a payment has been applied to the account. Now this prevents you from refunding. This is what I would suggest, having this language or a language very similar to this into your 501 or financial assistance policy. And it is required. These two things, the 6 months prior, the date of application, is required in there. Now this third one, underlined, is just an add-on. So let's go through some of these things. Why do I think this is the best? Well, I think it's the best because you put in there that you're going to give approval even including subsequent emergent or medically necessary care. So that way you do not have to reprocess applications constantly. So 6 months ahead that you can look at any subsequent emergent or medically necessary care, and that patient will be qualified unless a change happens in their financial situation. Why do I think the date of application is best? Well, the reason why I think the date of application is the best, it's because, like I said before, a person's financial situation can change in 240 days. I think the date that the person turns in that application is the date that they should be qualified for financial assistance. And why do I think it's best to have the language in here that talks about all outstanding receivables, including those at a bad debt agency, unless a payment has been received on those accounts? So this language here. I think this is the best because, number one, if the patient cannot afford to pay you, and they cannot afford to pay you on the date of the application, what's the likelihood they can afford to pay you on old accounts? Most likely, it's none. They can't afford to pay. So why not take that qualification process and rebucket those accounts, all of those accounts that are in bad debt, rebucket them as financial assistance. The patient cannot afford to pay. The likelihood of collecting it is slim to none. At that point, your best bet is to rebucket those as financial assistance. Let's move on to the next one, presumptive determinations. One of the requirements in 501R is that if you're going to use a presumptive determination model, that you have it inside your financial assistance policy. Now, it's not required to have or use presumptive determinations, but my strong suggestion to you is that it's worthwhile considering putting this into your financial assistance policy. Again, really what it does is reclassifying bad debt as presumptively eligible for financial assistance. So the two things that you're going to have to do, one, like I said, the criteria needs to be described in your financial assistance policy if you're going to use presumptive determination. And number two, you're not prohibited from using third-party information sources to make eligibility determinations. These two things together allow you to make a presumptive determination. So what is presumptive determination? It's using third-party information, and I'm going to talk about this later on, about bankruptcy, deceased information. It's using some sort of demographic scrub. So there's different companies out there that do a demographic scrub to make a presumptive determination. And it's also using a credit check, or could be using a credit check. So if you do a soft hit, which a soft hit means that only the patient can see that you've inquired about the credit bureau. No other individual can see it besides just the patient. You do a soft hit to take a look at it. One of the nice things about the soft hit to credit thing is that it's really, you're looking at the financial eligibility of a patient. One thing I don't like about the credit soft hit is I don't think it gives you the patient population that you're searching for at that time. So what I mean by that is 80% of the United States population, about 80%, has a credit file in the United States. There's a 20% of that population that does not have a credit file. That 20% of the population are probably the most indigent patients, the ones that cannot afford to pay you. And what a credit check does sometimes is those individuals that can't afford to pay you, that 20%, those are the ones you probably want to qualify for presumptive eligibility, but that credit check is not giving you that information. And that's where the demographic scrub does a really good job of. It really drives home to say what's the social economic status of that household. It's usually done by a zip. So your zip code plus 4, meaning the last 4 digits on the zip code, the additional 4 digits that you can see sometimes on address labels. That 4 digits really drives down to the household of that individual. And when you look at a household, you can tell a lot of different things. You can tell what's the value of the house, what's the median income in that area where the house is located. You can also drive down to some of the things that they use, that I've heard they use, is fishing, hunting license, magazine subscriptions, what kind of vehicle they drive, and other demographic information that's public record. So they can drive down to those those items, and these are really the 3 kinds. So let's talk about some a little bit more about presumptive determination. If you're going to use presumptive determination, understand that if you do it for less than the most generous, meaning if you do not give 100% discount. So let's say you use presumptive determination to give a 50% discount. If you're using it for that case, you have to follow all the requirements of 501R. So I would strongly suggest, in most facilities I looked at, if they're using presumptive determination, they're doing it on 100% qualification for financial assistance, meaning they're giving away free care. Make sure you take a look at that when you're using presumptive determination. You really probably want to do the free care if you're going to do it. There's also a no-no to presumptive determination. You cannot use it to tell someone they're ineligible for financial assistance. You cannot say that I looked at your credit score and your credit score is doing fairly well, so you're not eligible for financial assistance. That's a complete no-no. You can't do that. So make sure when you're using presumptive determination, it's only for qualifying people. That's it. So let's give you some examples. Example number one comes from one of my clients. XXX, and when you see XXX, understand it's the hospital facility, may utilize a third party to conduct electronic review of the patient information to access financial needs. This review utilizes a healthcare industry recognized model that is based on public record databases. This predicted model incorporates public record data to calculate the social, economic, financial. I'm not going to read the rest. This is just one example of how to put in your financial assistance policy to use presumptive determination. Let's look at example number two. Example number two gets a little bit more in depth. It talks about giving 100% financial assistance. So they qualify and say, we're only giving away 100%. Example number two talks about using what's called a healthcare credit score. So they're taking a credit score of less than 620, and this number, remember, can change based upon what credit score you purchase through available sources. But not only that, not only the credit score are they utilizing for this, but they're also utilizing these three items down below. Those that are homeless or receiving care from a homeless clinic, those who are deceased with no assets, and those that have been approved by the bankruptcy courts. Remember, as I said before, you can use other provided information. So if a patient's bankrupt, you're presumptively qualifying them for financial assistance, or this facility is. Let's look at my suggestion. And of course, my suggestion is really long, so I'm sorry about that. And I'm going to walk you through why I went through this suggestion. So presumptive financial assistance eligibility, XXX hospitals that some patients will be unable or otherwise unresponsive to traditional financial assistance processes. Basically saying, we're going to use this for unresponsive patients. In an effort to remove barriers for these patients and improve community benefits, the hospital will utilize public record and or electronic screening processes after all funding sources have been exhausted. Excuse me, that's important, in my opinion. Because if there's the possibility to have the person eligible for any other funding sources, I would want to use this first. Presumptive eligibility should really be used for those that cannot qualify or unresponsive to qualify or eligibility for any other funding sources. That information returned via an electronic screening process that will constitute an adequate documentation underneath the hospital's policy. Below are the 6 cases. Oops, sorry. Those 6 cases: A, patients without any third-party coverage and without the ability to qualify for third-party coverage will be scored through PARO. And PARO is one company that offers this financial assistance scoring. And we partner with a company that does PARO scores. And utilize that score in order to do some determination on our early out side when we're making the accounts in early out. And the reason why we use PARO is that's really a demographic-based score. But here's one way to word it in order to use presumptive determinations. So the first my true self-pay patients, I'm going to run them through a PARO score, a demographic-based score. And I'm going to cancel all of those that would qualify for financial assistance. So PARO is number 1. A. B, let's talk about B. B is a credit score. Patients listed for collections will be scored because almost every collection agency scores your account, either using some credit check or presumptive determination, or credit check or propensity to pay score. So patients will be scored at the collection bureaus, through a credit bureau or collection bureau. All accounts that score below a 499 and have no payments will be qualified for financial assistance. What B is doing is B is using your entire patient population. So all those that are true self-pay and all those that are balanced after insurance, it's scrubbing 100% of those, especially when you list it with your collection agency. That collection agency can take all of those accounts that are below 499 and send them back to you. And there's a reason why I would suggest utilizing this model. Number 1, those accounts that score below 499, the collection percentage in our history has been under a 0.01% chance that we collected. So I would suggest canceling those accounts back and rebucketing those as financial assistance, because your collection agency has less than 0.01% chance to collect those. And then also including in here, like before, some of the other demographic information, such as homeless, deceased, approved for bankruptcy, and another one that I've seen on many different facilities is utilizing a program such as a food benefit program, such as the SNAP program. If the patient is qualified for the SNAP program, most likely they're an indigent patient. So as long as they qualify for that, I'm going to approve them for financial assistance as well. I want to clarify something on this a little bit, is you do not have to use all these together. You could just use C, D, E, and F. You do not have to use A and B. You could just use A, C, D, E, and F. You can use B, C, D, E, and F, or you could just use whatever combination of this. You do not have to use them all. It's just my suggestion that my suggestion would be to utilize them all. This would allow you to qualify as many individuals presumptively eligible as possible. So let's talk about a little bit more about some of the requirements. 501R in the pre-publication document talked about that you can utilize oral applications if you would like. So if a patient comes into your facility and just is, and you want to be able to qualify that patient orally, it is allowed underneath 501R. You just have to make sure your financial counselors understand that they can qualify individuals using oral applications. The next requirement underneath 501R in your financial assistance policy, this is the one that I'm seeing a lot of times, the policies that I've been reviewing, a lot of times I've been kicking back policies and saying the requirements require you to list the documents. List the documents that you're going to be using to make your financial assistance determination. So if you're asking for a W-2 on the application, it should also be in your financial assistance policy. It cannot just be on your application. You have to list all those documents. If you're asking for 2 pay stubs, that has to be on your financial assistance policy. The policy itself needs the documents that you're asking for. And if your policy does not ask for documents, you cannot deny based upon the lack of the documents being provided. So if your application alone says documents, you cannot deny based upon the patient not providing those documents. Your policy also has to ask for those documents. So if there's one thing you have to do, make sure that the documents are listed in your financial assistance policy. So what are some reliable evidence? And the IRS gave you some, like I said before. Your federal tax returns, pay stubs, documents and established qualifications of certain other states' means-tested programs. And a suggestion that I have for you, and what the 501R requirement said, is have a language in there that says if these are not available, if these documents are not available, the patient may call the hospital's financial assistance office to discuss other evidence they may provide. Have some sort of language in your requirements that talks about the other documents as well. One thing I want to put the brakes on for, it's something that I've had many discussions on, especially in rural hospital areas. So this section, if you're not a rural hospital, this does not apply to you. But for those that are my rural hospitals that are on this call, there's something called the Healthcare Professional Shortage Area, or HPSA. And one of the requirements of HPSA, and what HPSA really does, it basically provides doctors payments for their medical or for their college tuition bills. So they get to be paid backwards for the college tuition bills in rural areas for practicing in a rural area if their facility or if the hospital qualifies as a HPSA center. So if you are a HPSA center, or if you're in a rural area and you're a HPSA hospital, if you're asking for assets, meaning if you're asking for someone about 401k, their house value, if you're asking for that sort of information on your financial assistance policy, it disqualifies you from HPSA. So just understand that when you're updating your financial assistance policy and application, if you're asking for assets and you're a HPSA facility, it'll disqualify your physicians from getting repayment on their loans. Just be careful of that, rural facilities. Requirements, another requirement along with 501R is that you have to specify eligibility in your financial assistance policy. You have to specify what that eligibility is. I've seen many different policies that have come to me that didn't really talk about how they're going to qualify someone. And the majority of times, when you specify your eligibility, or most facilities, what they're using is the federal poverty guidelines. And I have an example. Example number one is a federal poverty guidelines. They're using 250% of the federal poverty guidelines as established annually by the Department of Health and Human Services. They specifically state the eligibility requirements. That's what the IRS really wants you to do in your financial assistance policy. Don't just say that people will be eligible. Specify down to the 250% or whatever that number is, 200%, 300%, 400%, whatever those sliding scales are. You have to specify that in your financial assistance policy. Another requirement of 501R, you have to, part of 501R, is state that your AGB, that your facility will not charge more than the amounts generally billed for emergent or medically necessary care. So make sure your financial assistance policy has some sort of statement that says what your AGB is and how an individual, or that they will not be charged more, someone that's eligible. And that's the key word on this one too, is especially with AGB. AGB is only required for those that are eligible for financial assistance. It's not for all self-pay patients. It's only for those that are eligible or qualify. I'm sorry, I said that wrong too. Only those that qualify for financial assistance. AGB is only required for those that qualify for financial assistance. But you have to have some sort of sentence in your financial assistance policy that says individuals will not be charged more than the amounts generally billed for emergent or medically necessary care. One of the suggestions, I found this to be fascinating, that a facility in Michigan is doing this, and it's Spectrum in Michigan if you want to look up their financial assistance policy. But what Spectrum has decided to do is absolutely remove their sliding scale. And by removing their sliding scale, what they do, by removing their sliding scale, they remove AGB. They no longer have to provide AGB. And the reason why they're doing it is because they're giving 100% discount to everyone. Anybody that qualifies for financial assistance will receive 100% discount. And by doing that, they no longer have to do AGB at all. This is the what's on your screen now about physicians on your financial assistance policy is probably the second most forgotten requirement of 501R. 501R requires that you list all physician practices who provide emergent or medically necessary care at your hospital. You have to list all those physician practices on your financial assistance policy. And you have to quantify or qualify which ones follow your financial assistance policy and which ones do not. So only you have to list all physicians that practice emergent or medically necessary care. And last summer there was an update on this one. The IRS released that you don't have to list each individual name of physicians, but physician practice groups. So if you use radiology AGB or ABC, radiology ABC, and radiology ABC does not follow your financial assistance policy, you have to put them in the list that says they do not follow it. Now let's say your emergency room docs follows your financial assistance policy. Then you would have to put them in a list that says they follow your emergency or your financial assistance policy. So every single one of your physicians that practice emergent and medically necessary care has to be on your financial assistance policy, with those that follow your financial assistance policy and those that don't. And if they, if there's certain circumstances only where they follow it, you can list that on there as well. they did say one thing that's hugely important. This physician list can be included as an appendix. The IRS opened the door to appendixes with this statement. And I'm going to talk about that a little bit more later on, about why appendixes are so important. You only have to update that list if it is changed. So if that physician list does not change, you do not have to update it. But if it does change, the IRS is requiring you to update that list quarterly. So let's say a new practice, new physician groups comes to your hospital to practice emergent or medically necessary care. You have to update that physician list on your financial assistance policy quarterly to include that new practice. So like I said, appendix. Appendix should be your new best friend, and no, not your bodily appendix. But why I think your appendix should be your new best friend is because there's a couple things that I would highly suggest be a part of appendixes. And number one is your AGB. If you're using a look-back method, I would suggest that your AGB be part of appendix. Number two, your physician list, as I said before, you should have that as appendix. And number three, federal poverty guidelines. Here's the reason why I think these three documents should be an appendix. The IRS requires that your governing body, or whoever your governing body gives the admission or approval process to for your financial assistance policy, approve your financial assistance policy before it is put out to the public. So anytime you make changes to your financial assistance policy, you're asked to get your governing body's approval. In most facilities, that's your board of directors. So imagine bringing to your board of directors every single time your AGB percentage changes, or every single time your physician list changes, or every single year when the February poverty guidelines changes. Those three documents should be an appendix. That way, when they change every year or quarterly for physician lists, that you do not have to bring the full policy to your board to get approval. That's the reason why I suggest that you use this as your appendix. Another requirement for 501R is that you put in there what is not covered by financial assistance. You're required to have in your financial assistance policy what is not covered. So is it the elective procedures? Is it a Medicaid or Medicare definition that you're going to utilize? But you have to have some sort of documentation of what is not included. And I'm going to give you examples. One is on the screen right now. It's talking about what is not included. So elective procedures, services from other care providers, and deductibles and co-insurances are not included. This is one example from one client of mine of what is not included. You could find others how you really want to kind of take this on, the Medicare definition, or this one uses the Medicare definition, but make sure your financial assistance policy has in there what is not covered by financial assistance. That's required by law. So look, I'm going to give you some suggestions for the next couple slides, and these suggestions are not part of 501R. It doesn't require it under 501R. These are just suggestions for me reviewing so many policies that I really want to give you some other ones. So here's one. I'm going to fly through these pretty quickly. I thought this was a great idea as well, is that they had a community residency requirement. Basically, to improve the mission of the health communities they serve, they will only consider those applicants that reside in their communities they serve. It's a way to narrow down so that you don't have a transient population coming to your facility to get approved for financial assistance because you're the easiest to get approved for. Another thing I thought was a very interesting thing that one of my clients put in their policy is third-party payers exhausted. They had a list of requirements that all these third-party payers be exhausted before financial assistance. And I think it's a good idea to have some sort of what third-party payers are going to be exhausted first. And the one that I thought was very interesting, because we see this from time to time as well, is pending litigation. Those patients with pending litigations, those that are about to receive a work comp claim or those that motor vehicle accident claim, those pending litigations really should not qualify for financial assistance. They should be, the pending litigation should be solved first before it goes through. So I thought that was quite interesting. Again, feel free to utilize or use any of this information in here. Another one that you want to make sure that you have in your financial assistance policy, because there's additional bucketing of financial assistance, and this really drives back to a webinar I'm going to host later. I believe it's in September, in regards to how to fill your financial assistance bucket. But the 990, the IRS basically said any discount that's in your financial assistance policy, you can include on your 990 as financial assistance. So what I mean by that is, I know some facilities have been putting in theirs that patients will be receiving an uninsured discount of 25%. That uninsured discount, if it's in your financial assistance policy, is considered financial assistance. So as long as that discount is stated in your financial assistance policy, you can actually bucket that 25% as financial assistance. So in saying that, make sure that any discount, additional discount that you put on accounts, and you want to rebucket those as financial assistance, there's the capability to do that based upon the new 501R regulations. Another one, I have seen this in many different facilities. They're using catastrophic care, meaning that even those patients that are gainfully employed and have a good job, there's something as catastrophic care, meaning that they can qualify for financial assistance if something catastrophic happened in their life. So in this instance, it's saying that if the bill exceeds 25% of the family income, and this is important, family income, and have assets below the equivalent of 600% of federal poverty level thresholds, then they can qualify for catastrophic care. In today's world, with high deductible health plans, there are going to be patients that are going to rack up $100,000 worth of charges, even with insurance. And those patients need a way to get out of that medical bill. And some of them will not have the capabilities to pay the bill. This is where catastrophic care comes in. It allows you to qualify some of that balance for financial assistance in order to help the family out that has that huge medical bill. Example 2 is another way to word the catastrophic discounts. So both of these are available on the slides. Please take them if you'd like as well. So let's move on. We're running close to the end. I'm sorry. I think I'm going to go over a little bit on this one, but I think it's important to keep on going. So one of the requirements of 501R for is to create something called a plain language summary. And what a plain language summary is, it's really a simple explanation of financial assistance. So you have to create a plain language summary, which is a simple explanation. And you're going to use it in 3 different ways. Number 1, you have to mail it at least once to all patients that you intend to do extraordinary collection actions on. And my suggestion to you, when you mail it, it should be the backer of the statements. Put it on the back of statements, your plain language summary. Number 2, it needs to be available in conspicuous public displays. So that plain language summary needs to be available so a patient can pick it up any place. Number 3, it needs to be available in the admissions and emergency department for free. So you also have to make it available in the admissions and emergency department for free. So what is required on the plain language summary? Number 1, your direct website address and physical locations where the individual can obtain copies of your financial assistance policy and the application itself. Number 2, requirement on that plain language summary, the physical location of hospital staffs who can provide assistance. So you have to have a location. So let's say you have a facility and the admissions department of the hospital is the place where your financial counselors are located. You have to put that address or location where they can receive assistance. I would strongly also suggest having the phone number that rings directly to those financial counselors so they can receive assistance as well. And number 3, you have to have on there how a person applies for financial assistance and what's the requirements for eligibility. So some sort of, you apply, and our federal, you're qualified based upon your federal property guidelines of your family income and stating that out as well. So how an individual can apply. Let's talk about that physical location for assistance. You do need to have where that is located in your hospital. And one of the things the IRS changed in the final regulation stated that you actually need to have the room number and phone number of the appropriate offices or department to contact. So you have to have some sort of room number and phone number where those financial counselors are located. All right, enough about plain language summary. We're going to dive into now, part of 501R4 is widely publicized. This is another requirement of 501R4. So there's 5 real requirements to be widely publicized. Number 1, you have to have paper copies available at public locations. And paper copies, what I mean by paper copies is, and I think I'm going to talk about this in the next slide, you have to have your financial assistance policy, your billing and collection policy, the application itself, and then also the plain language summary. Those 4 documents have to be available at public locations. And the IRS kind of clarified what public location means. It means your emergency department or admissions area. You have to offer those documents as part of intake for outpatients, or you have to offer it to patients as part of discharge for those that are inpatients. So a simple statement says, would you like a copy of our financial assistance policy? Your admissions and registrar people should be asking that question to every single patient. That's part of being widely publicized, is to have that language incorporated with your admissions and registration department. Like I said, the 4 documents that you have to have available, they're on your screen. But the key on this one, on this slide, is this, is that all 4 of those documents have to be translated at a threshold of 5% of the population or 1,000 individuals, whichever is less. So if 5% of your population speaks Spanish, you have to have all 4 of those documents translated. If 5% of your population speaks Greek, they have to be translated as well. 5% of the population, whatever language that is, it has to be translated if 5% of your population or 1,000 individuals. This is a big one that I think, it's not easy to get documents translated in 4 different ones. So once you complete your approval process is when I would really suggest that you look for a translator to document or to translate your information. The 5 requirements, I talked about only 1 so far. Number 2, it has to be available on your website. Those 4 documents have to be available on your website. The IRS really strongly suggests that it not be hidden in the patient section, someplace easy, accessible for the patients to get to. Didn't require it, but they strongly suggested to make it easy for patients to get to that information. Number 3, to be widely publicized, this is a change in the final regulation that every single written notice, every single statement really that goes to a patient has to have a telephone number and direct website address where a patient can get assistance for financial assistance. So a simple statement is financial assistance available to those who qualify. Please call with the phone number or visit our website at, has to be on every single one of your statements that you mail to patients. Number 4, to be widely publicized, the IRS is requiring that you have conspicuous public displays. Those displays have to be in your public locations, emergency and registration areas. They have to attract visitors and be of noticeable size. So you have to have signs about financial assistance throughout your hospital. And number 5, you have to notify and inform the community. They did not specify what notify and inform the community it means, but you also have to notify and inform the community, part of 501R4. Perfect. Sorry for going to 5 minutes over, but as you can tell, this is an in-depth topic that sometimes can take a while to discuss. everything that I've went over. If there's any questions, my cell phone number is available. That's my cell phone number on the screen, along with my email address. If you did ask questions during the time frame, I'm sorry, because of the time, I'm going to have to email you the answers to those questions, if that's okay. And if you do have any questions or like me to review your financial assistance policy or your billing and collection policies, feel free to send them my way, and I'll give you some suggestions on how to some of the requirements if I'm seeing anything missing, or some suggestions on how to improve those. But thank you very much for your time, and truly appreciate you joining in. Hope you join us next week for 501R6. You're basically talking about your billing and collection policy and what are the requirements of a billing and collection policy, along with extraordinary collection actions.